I am humble and honored to introduce Dr. Bergersen. Dr. Bergersen got his DDS, his MSD from Northwestern Dental School and is a board-certified orthodontist. He taught at Northwestern University postgraduate program of ortho for 24 years, and he was a practicing orthodontist for 35 years. He has developed the only preventive orthodontic appliance for use in 5 to 7-year-olds. In addition to the Nite-Guide appliance, he has developed other appliances for patients of all ages. He holds, I think, 511 US and foreign patents. These appliances have been used nearly in 4 million patients and have been distributed for over 49 years. Dr. Bergersen has lectured worldwide, I think giving over 500 seminars. He's probably lost count at this point. He's published over 80 scientific research articles and has been a research advisor and lecturer at several universities. 2 quick personal notes. First, I personally attribute a great deal of my personal systemic health and quality of life to Dr. B. I was a horrible thumbsucker as a child, and as a result had severe dental crowding. I had chronic allergies. I was just a really, really sick kid. My dad, who is a dentist and is also here today, took me to a couple of orthodontists in the area to consult kind of how to treat this, and all of them universally said, well, wait until she's done growing. She'll be a 4 bicuspid extraction band and bracket case, and that's all we can do. That was not very intuitive to my dad. He did not want to take out healthy teeth on his child, so he went on a search and fortunately found Dr. Bergersen, became a student of his, and as a result, they resolved my poor oral habits starting, I think, at 7 or 8 years old, guided the remaining growth and development that I've had, and as an adult, I've ended up with very broad smile, healthy joints, healthy airway. I've never worn a retainer. So I'm very grateful. I'm a very healthy adult. I'm a great sleeper. So I attribute that to Dr. Bergersen. I'm very grateful. And as a result, I'm grateful to have him as a mentor. Last little thing I would say, if you want a chance to meet Dr. Bergersen, make sure to do it today. He will be flying back home tomorrow to celebrate his 62nd wedding anniversary with his wife. So, thank you.
I love Boston. As a matter of fact, I used to give my wife a birthday present, and I would bring her to Boston from Chicago, and she'd go to Filene's special sale in August, and as a result, I have an extra room in my house, which is a woman's closet, full of clothing, full of shoes, full of purses. I can't even play golf because I converted a golf cart garage into a woman's closet, so you can understand. Anyway, she's a good friend of mine, and we're celebrating our 67th, or 62nd rather, anniversary tomorrow, so I'm glad to be here. Thank you. The disclaimer, I'd just like to mention that I am the inventor of these appliances. I do not have any financial interest or product of my talk anymore. I do not own any stock in the company at this time, and I do not receive any grants or anything else that has supported myself. So anyway, we're going to be talking about breathing and malocclusion issues in the pediatric area of dentistry. I've always been interested in, see if we got this right here. Actually, my passion as an orthodontist really has been in prevention. And anything that I've been able to do, I would like to pass off to the child and make his life easier or her life easier, make it as good as orthodontics is, for example, for orthodontic appliances, and I do want that to be passed off to the patient. So I'm kind of a renegade orthodontist, I guess you could call me, but I've enjoyed doing that. And when I can make a patient be more successful in what they're doing, even at a lower fee, and open up orthodontics to a greater segment of the population, this is really what's worthwhile. So anyway, we're going to talk basically about sleep issues and how it relates to dentistry. Sleep issues start in the oral cavity. Almost 80% of all sleep issues are a result of the mandible slipping back during sleep, and since the tongue is attached to the mandible, the genioglossus muscle is attached to the genioglossus tubercles, upper tubercles in the mandible. If the mandible slips back, so does the tongue. And when the mandible slips back and it opens up, the muscles relax, the masseter muscles relax, the external pterygoid maxillary muscle relaxes, and so that the mandible is allowed to go back. An opening of 1/2 inch, for example, will close up the airway 6 millimeters. Well, the airway for a young child is as large as their little finger. And that airway for an 8-year-old or a 6 or a 5 or a 4 or 2-year-old might be only 7 or 8 millimeters in diameter, which means that the child has to breathe all night long, or at least when they're mouth breathing, into an airway that might only be 2 millimeters wide. You try breathing through a straw from a Starbucks coffee shop sometime and see how long you can breathe and how much it feels to you, how terrible it must be for a young child. So we're interested in seeing what we as dentists can do for young children that suffer from sleep issues. As you listen to me, I would like you all to think of your own children, your sister's children, or even patients in your own practice. How many of them might have some of the symptoms that I'm going to tell you about? We have a questionnaire that we hand out to a parent, and it has 27 symptoms of sleep and several symptoms of speech as well. And when the mother starts filling that out, all of a sudden they begin to realize, oh my gosh, one of my children has so many of these symptoms. And the average child in a dental office that comes into you only for a dental exam has an average of 7 symptoms characterized by sleep issues. So it is an unbelievable problem in the United States. 90% of children have one or more of these symptoms, so we feel that almost 85% of children are probably candidates for some form of treatment. So anyway, I'm going to show you a little child here. This is Eli. The characteristics for what we call apnea, which is a complete closure of the airway because of the mandible slipping back, the tongue slipping back as well, and it impinges on the anterior wall of the oropharynx. At the same time, the muscles that hold the airway open are also shortened, and they do not keep track of the airway, and they let loose of the airway, and the airway tends to collapse. The rules for a young child, for example, right now are not exactly set in stone, but they represent 2 breathings of a child. A child breathes faster than we do, and so each breath is 2 seconds long. So 4 seconds long in 2 or more of these symptoms per hour is called sleep apnea for a child. In the adult, for example, in my case, I have 70 wake-ups each hour every night. So I have severe apnea. And the diagnosis of an adult is really 10 seconds or more of stoppage of breathing 10 times or more per hour. So this little boy, when you watch him breathe and struggle breathing, I want you to kind of count the number of seconds that he stops breathing, 1,000, 2,000, 3,000. So let me go down and see if I can, it's hard for me to.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. Still holding his breath, and he's going to gulp again. There he goes.
Now he starts breathing again. That was at least 10 seconds long. Here he is again. He's not breathing.
Again. He's holding. He's holding. He's trying. There he goes.
Now he breathes. You see where the mandible is? It's downward and backward.
3 minutes and 15
His tongue is
seconds.
pushing
You can see how
against
many
his
episodes he's
oropharynx,
had
closing
of
it
not
up.
getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it
Now this
forward.
procedure is exactly what
Can.
one of these appliances are doing.
And I open his airway.
She's pulled his jaw forward
Just bring his airway forward.
and allowed the airway to be open. No apnea. It clears it up.
Now listen to the quiet breathing. There we go. Now he's breathing through his
Now he's
nose.
sleeping normally. How that affects that boy all night long,
Airway, I'm opening his airway. Just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose.
now if he had to wear an appliance
Just by-
all night long that would maintain
he's
the
breathing,
position
you
of the
don't hear me.
mandible in its anterior
And all I
position
did
in
is
relation to
gently
the upper
bring
arch,
his jaw forward.
he wouldn't have apnea. What does apnea result in? Well, when they close that airway down, it means that they have less air. So suddenly the hormones stimulate the thorax to pump more rapidly, to get more and more air in because there's lack of oxygen. And as that air speeds up, it starts the uvula to vibrate, and that causes snoring. In some cases, not all cases. But that's what causes this. Now, if the child loses oxygen, it affects almost everything in the body. It is the most important chemical that we have in our body. And it affects the immune system, the endocrine system, and the neural brain system. So these children suffer from all symptoms that are controlled by these areas of the body. So we're going to talk about some of the factors that we as orthodontists can do to help a child not have sleep issues. A lot of these sleep issues are connected to what we see in the mouth: tongue position, swallowing, oral breathing, lack of nasal breathing, open bite, narrowed maxilla, retrognathic mandible. All these things play a significant role in how that child sleeps. So we'll just briefly go through some of these things. And mandibular retrusion. Well, obviously, the further back a mandible is for a child in normal occlusion, probably the closer that is to that airway, the closer the tongue is to the anterior wall of that pharynx. And any little bit of retrusion will close up that airway. In fact, mandibular retrusive cases have narrower airways than children that have a normal mandible. Mandibular vertical growth. The electromyographic recordings on the masseter muscle, when the mouth is open, they're breathing through their mouth, the electrical recordings of the masseter muscle are less, so that it has not as much force to control the vertical growth of the face. And so the face grows longer. This is a tendency. You can look at a child, and if their face is long, you can probably bet that they have a sleeping issue at home. Nighttime mouth breathing. I've already mentioned most of the factors of mouth breathing. Mouth breathing is the most prevalent of all the symptoms. In fact, it varies from about 45 up to 70% of children mouth breathe at night. It's an unbelievable problem. And any child that is mouth breathing at night, you should be suspicious that there are probably 7 other symptoms that that child is suffering from as well. We figure that if they have 3 or more symptoms, we should be treating that child. so that about 80% to 85% of children should be being treated for sleep abnormalities. Daytime mouth breathing. Not all children that breathe through their mouth breathe through the day as well, but usually daytime mouth breathers also breathe at night. It's not as prevalent or popular or frequently occurring as nighttime mouth breathing, but it is there. Overjet. Overjet is the horizontal positioning of the upper jaw to the lower jaw. More overjet means that either the upper teeth are forward or the mandible is back. In most cases, it's a combination of both, but overjet is directly related to increased sleep issues. Even overbite. A deep overbite retrudes the mandible. It can't come forward as much, and it causes TMJ problems frequently, but it also causes sleep issues. TMJ, not so much, but anytime you have a superior or posterior displacement of the condyle, it puts the mandible and the tongue in a more posterior relation. Crowding. Crowding is in the upper arch is characteristic of a narrowed upper arch. Anytime you have a narrowing of the upper arch, you have less nasal breathing. If you don't have nasal breathing, believe me, you're going to be mouth breathing. And so the object is to stop mouth breathing, encourage the child to have nasal breathing, and open up the airway. These are the three elements that we must look at in every child. Bruxism. Most bruxism is associated with restless sleep at night. There's a direct correlation between the two. Bruxism, we can correct almost 50% of bruxism by just changing the sleep problems of a child. I don't know how to correct bruxism. I've never had a good way of correcting bruxism until I started treating sleep issues, because we can get a tremendous effect on bruxism in young children. The same reason, the child might be sleeping in bed at night and they throw their arms all over and their head will end up at the bottom of the bed and the feet are at the pillow at night. If a child ever comes in and sleeps next to you at night, their arms are swinging, you might get hit in the face with one of their arms. They sit up and talk, they sleepwalk, they have nightmares, they scream at night, they get out of bed and come into your bed, and we've had parents that will actually, 3 o'clock in the morning, put their child in the car and drive them around in the neighborhood until they fall asleep, carry them up and put them in bed. Half hour later, he's up again screaming and going into the mother's bedroom. There are parents that are losing sleep and they have job problems because of children that don't sleep right. So it is a major problem, even for the mother or father that has to put up with this. Lingual crossbites, posterior crossbites, severe ones, are usually due to a child putting the thumb in the mouth, and the thumb is narrower than the tongue. They put it in the palate. The tongue belongs in the palate. It does not belong in the mandible. And so the thumb is in the palate. It's narrower. They create a vacuum and it pulls the upper arch in. So it pulls it in so far that the child can't bite normally. So they shift to one side, and that's called a functional crossbite. Most of these crossbites, you can tell if a child has a functional crossbite, believe me, they also have a sleep problem. And so lingually inclined upper incisors does not allow the mandible to come forward as much when it grows. And so it's pushed back. It becomes displaced distally. And this also puts pressure against the anterior wall of the oropharynx. Thumb sucking, the worst of all. A child that thumb sucks, that thumb is up in the palate and they create vacuum. If you have a hard time getting the thumb out of the mouth, boy, they're doing damage, believe me. And if that goes on too long, I used to, as an orthodontist, correct this when they started school. I don't do that anymore. If the child is 1 year old, I'm going to correct that thumb problem, because that thumb problem will cause oral breathing. It'll cause all sorts of other issues with sleep. Abnormal swallowing, the tongue comes forward. It's not up in the palate when they swallow, and this causes problem. Abnormal tongue position. If the tongue is always in the mandible, and you cannot breathe with the tongue in the palate through the mouth. So mouth breathers have the tongue low. They've been taught how to do this. They use pacifiers a lot. They suck their thumb. They might be bottle fed, and the nipple goes up in the palate, and it allows the suction to create cross bites, and they develop usually an abnormal tongue position and swallowing. Open bites are a result of abnormal swallowing habits as well. Mid-face retrognathism. If a child has mid-face retrognathism, we would recommend that it be pulled forward because that does impinge on the nasopharynx in the back. They have speech problems. Probably at least 1/3 to 1/2 of all speech problems involve not putting the tongue up in the roof of the mouth. And so we have a new questionnaire that we're giving to people where they can have the mother analyze exactly what speech problems they have. A lot of these children, 25% of these children, do have speech problems. And frequently, if a child has speech problems, they also have ADHD, attention deficit hyperactive disorder. It's two symptoms that a child has that are put together that create school problems and so forth. Prolonged nipple and pacifier use and posterior lateral tongue thrust. So a lot of these things are potential problems for us. The anatomy of the airway should be open all the way down here. The ones that bother us the most are what we call the oropharynx. It's behind a long palate, soft palate, and it's behind the tongue. These are the major problems that a child might have. And anything you can do to keep that tongue forward is a help. Who's in charge of mouth breathing? The dentist. Who's in charge of cross bites in the upper arch, retrognathic mandibles, and all the rest of it? It's in the oral cavity. The physicians don't know how to do these things. The first line of defense for the physician is to have the tonsils and adenoids removed. Well, only 10% of children really require tonsils and adenoid removal. And no wonder when they remove them, they don't correct the problems. Very rarely. Obese child, 10% improvement with a adenoid tonsillectomy. So these are not things that can correct the problem. So the main area is the nasopharynx. The palatopharynx is behind the palate. The upper part is mostly due to adenoid swelling and interference with nasal breathing. A child that has a cold when they're young. For example, most of the issues that are habits can be formed very easily in a young child, and they can be corrected very easily. So anything that can be corrected with an orthodontic appliance or with myofunctional therapy where they retrain the muscles of the bicularis oris and the oral cavity and placement of the tongue, these are acquired habits and these are easily corrected. So mouth breathing is an easily corrected habit, and it can be corrected at any age. We can put an appliance in there that will correct it at 1 year of age, for example. So anyway, here's a child in the womb, 4.5 months old. This is the time when a child suddenly realizes that they can suck, and they develop sucking habits many times. A lot of children suck their thumb in the womb. I want you to take a look at the mandible. Do you think that's being affected by that thumb? If that thumb is in the mouth of that fetus, that mandible is not going to be able to have the kind of growth that is necessary to have a normal facial profile. So we're very concerned about children like this that start sucking their thumb the minute they're born. They come out of the womb almost sucking their thumb. And so these do have to be corrected. When we take a look at growth factors, for example, if you look at a child that grows until the teeth are erupted, tremendous amount of growth. It's the fastest growth period of any time in that child's lifetime. And the mandible grows downward and forward very rapidly, and that changes the newborn infant's mandible into a more normal facial characteristic. Once the teeth are erupted posteriorly, once the first deciduous molars are erupted and in occlusion, there is no change in that arch relation between the upper and lower arches forever. It'll be the same when they get to be 60 years of age. So it doesn't change according to research. So we know that if we're going to do something, we can prevent it from happening at an early age. Now, we can advance the mandible also at 12 years of age, 13, 15. Any time when they are still growing, we can do that. But it's so easy to do it at a young age. So these are the growth patterns. About 75% of children have this pattern. Now, not all children have that pattern. Sometimes they don't have that pattern, but they still have a lot of growth. You can see the straight line pattern here, and we even have marked where the tonsils and adenoids were removed and where the teeth incisors became occluded. So we see changes in the direction of growth, for example, but it usually assumes the same direction that they're born with later on. This direction of growth probably is a result of the force of the muscles. We had a study done at Northwestern one time. We had a student that checked the slope of the mandibular plane and length of the face with the strength of the masseter muscle. Well, the children that had a longer face with a steep mandibular plane angle had 50 to 70 pounds of force between the masseter muscles in the face. A person that had a more normal had 700 to 800 pounds per square inch. So you can see that if a child does not have the strength in the masseter muscle, it's not going to develop properly. So anyway, here's a girl that had no mandibular growth from birth on. And you can see the terrible problems that she's had. It has not affected the horizontal. When we measure from the opening of the auditory meatus to the front of the face, we see the same distance in all three. It's hard to see it here, but that's true. But they do have extensive growth lengthening of the maxilla because the mandible is not putting any strength. If all of you swallow for a moment, just swallow, you'll find that your upper teeth put tremendous pressure against your upper teeth, and that controls the growth of the maxilla. And as the mandible grows 30% faster than the maxilla, that biting force pulls the maxilla forward to compensate. But the cartilage of the nose has an independent growth factor, and that one is growing also. But you see the nose has changed tremendously for this girl, more so than most normal children. So when we take a look at a face of a child like this, we see tremendous problems. I mean, there's growth in length, but not in depth. So a child, this is why a child has a longer face if they have sleep issues, because they don't get the oxygen and they don't have sufficient growth of the mandible to keep going. This is what the face should look like. This is a normal growing face, and you see that the mandible, even though it is growing 30% faster than the maxilla, the relation between the teeth has remained the same from almost 25 months to adulthood. And so this is, we would like to establish a child to have this kind of a face so that when they grow, they're going to have a normal looking face. Not only that, they're going to have a normal looking sleep issue as well. So if they open the mouth a ½ inch, you get a closure of 6 millimeters of the airway. And if the airway is only 7 or 8 millimeters wide, this poses a tremendous effect on that child. So what do we have here? We actually have mouth breathing that starts up here, and they have reduced oxygen. So you can test the oxygen on one of these children, and the oxygen limits is supposed to be about 97 to 100%. It drops down to 90, sometimes in the 80s, which is very detrimental to a child. That oxygen is necessary to fuel the endocrine system, the immune system, and the brain. And it is found that brain cells enlarge during the day, and the hormones will decrease the brain cells at night, and the intercellular space opens up, and all the toxins are flushed out of the brain like the lymphatic system. And then the next day, the brain cells widen again or become larger, and they communicate again. They throw the toxins in between, and then they shrink again at night. Well, a child that does not have proper sleep the oxygen affects the endocrine system, and the hormones that control that can't control it anymore, so the cells become enlarged even at night. They don't shrink, and the toxins can't get removed from between the cells. Well, lo and behold, that same toxin, beta amyloid, is the same toxin that's found in adults that have dementia and Alzheimer's disease. They're trying to find out chemicals that will reduce the beta amyloid. Well, I tell you, I got a solution. You give a child an appliance at a young age and prevent them from having sleep issues, and you will prevent beta amyloid from occurring. My wife right now is in Chicago. I hate to leave her because she has dementia. She's been a mouth breather for as long as I can remember. We've been married for 61.5 years, and she has breathed through her mouth every night, all night long, all the time. She doesn't have apnea. She doesn't have the other symptoms that you normally see, but I am sure she has beta amyloid secretions that are between the brain cells right now that are affecting her. So it is a tremendous problem, and at some point they're going to find out these toxins have to be removed. So if you can find a way of reducing those cells, that's the way to do it. Anyway, what happens is that they have restless sleep. They wake up at night. They talk in their sleep. They walk in their sleep. They fall asleep watching television. They feel sleepy during the day. They have dark circles under their eyes. They look like they're ready to fall asleep in the dental chair. They don't have much of a personality. They're depressed. They don't smile. They don't like to be hugged as a baby. They resist being hugged. You tickle them, they don't laugh. I mean, these are characteristics of sleep issues even at birth. So what does that do? Well, that affects the brain, the immune system, and the hormone system. We've had children that have had eczema their whole life, and they've had I don't know how many chemicals in their system to try and prevent it, and they wear an appliance, and in 2 weeks the eczema's gone. We have children that wet their bed. They're constantly wet their bed. We had a 19-year-old girl that wouldn't apply to college. And a mother kept pestering her to apply to college. Well, she got in some dental office, and they gave her one of our dental appliances, and suddenly her bedwetting stopped, and she started to apply in colleges. And the mother said, was it because you wet your bed? She said, how could I go to college and wear a diaper or wet my bed every night? She said, I couldn't go to college. That girl probably has never had an overnight at somebody's house her whole lifetime. I was giving a lecture like this a while back in, I think it was San Antonio, Texas. And one of the dental assistants walked up to me afterwards, and she said, you've just described my whole life to me. She said, as a 7-year-old child, I was on 7 different medications, and I took those for almost 10 years. I became a drug addict when I was in my teens. 50% of children that have these problems become drug addicts in their teen years, alcohol issues. And she said, I haven't had a decent night's sleep in over 12 years. And she said, I wake up every morning with a driving headache, and she said, half the time I can't even go to work because I've got such a headache and I feel so sleepy. She went to an office, and a lot of it was corrected, I understand. So, you know, these are problems that people have. It's too bad that she went through all this time. She said she had a photographic memory. She got straight A's in everything but math. She flunked math. She couldn't pass math. Einstein had a math problem. He also had apnea. Thomas Edison had apnea, had sleep issues. He had to take a nap every afternoon. At the end of the day, they separate into 2 halves. One half are dependent on an adult. They can't organize their life. They don't know when to go to bed at night. They don't know when to wake up. They don't know when to eat a meal and so forth. It's all thrown off. The other half become extremely ambitious, like Thomas Edison. Ronald Reagan had apnea. He said, always wake me up if I fall asleep, especially during a cabinet meeting. So LBJ had apnea. So it is present a lot in adults, but it is also present as children. I would be willing to bet that Ronald Reagan had a sleep issue when he was a child because he also had Alzheimer's. So, you know, these are strong issues. Wetting of the bed, eczema, middle ear infections. They have a lot of middle ear infections. They're getting infections and sick all the time. They probably have a sleep issue. Increased appetite, weight increase. They develop diabetes sometimes. Growth, it affects their growth. Two identical twins, if one has a sleep issue, it usually is a couple inches shorter than the other identical twin. When they wear an appliance, they'll go through a growth spurt and they'll become the same height again. We've had a few cases like that. So, alertness, memory, judgment, attention. I had a patient that the teacher had to tie the chair to his desk. They had him run up and down the stairs several times during the day to try and wear him out. He had twice the recess things that other kids had. He came out of school, he would climb over the fence rather than walk through the doorway. He was hyperactive. His mother had to hold him tightly at all times, otherwise he's liable to run in the street and get killed. And that boy happened to be my grandson. And that little boy in second grade was flunking almost everything. We gave him an appliance, and by the time spring time came, he went from the 6th percentile to the 53rd percentile in math. He's now 17 years of age, and he's in an advanced mathematics program. His favorite subject is science. The three subjects that are affected by sleep issues are spelling, mathematics, and science. And so if you have a child that is having difficulty in math, check their sleep issues. Fill out a form. See how many symptoms they do have. Anyway, REM sleep. REM sleep is the type of sleep that restores the brain back to its normal position for the next day. It prepares the child for the next day. Some of these children have what we call slow wave or delta sleep more, and this is why you can drive them around, they fall asleep, you can pick them up, they don't wake up, you can put them in bed, they don't wake up, but when they have an episode of sleep, they do wake up. They don't dream, they have nightmares. The 22-year-old girl told me she never dreams. She never has a dream. That's a symptom of sleep issues. So here's an adult. They took brain waves the first day, and you can see the activity in the brain. You see the red and the yellow? His brain is active. He went to sleep that night, and they kept waking him up. Every time he fell asleep, they wake him up, so he couldn't get a good full night's sleep. This is the brain wave the next day, no activity. Now that's what a child goes through when they have a sleep issue, because their brain does not rid itself of all the toxins, and they are suffering because their brain is inactive the next day. They can't pay any attention in school. They're crawling all over the place. A teacher's explaining something on the blackboard, and the child might get up and walk over and look out the window. They're not paying any attention. And so this is the problem. People that are prisoners, and they try to train their brain to be inactive so that they'll admit to anything, go through this kind of a characterization. They keep them awake all the time. They don't let them sleep. If you don't sleep, it's disastrous. You'll die, so. Anyway, Ritalin. A guy told my daughter, this grandson of mine, he said, the only solution is Ritalin. She said, I don't want Ritalin. And he said, you'll be back in 6 months. You'll be begging me for Ritalin. Well, we gave him the appliance, and he did not need Ritalin. These are some of the changes that you see, things that people go through to get a solution for their child, and they come in and they think, oh my gosh, we've gone through all of this stuff. They tell them, keep your hands in your pocket. What does it help you? They have allergy testing, sleep studies, psychiatric testing. They told my grandson, keep your hands in your pocket. Don't push, shove, trip people. He was always doing things to other kids, teasing them and being not friendly. He wasn't making friends. Well, he's got so many friends. He fixes all his friends up with girls. I mean, There are sometimes he's got 6 girls over at the house cooking cookies for him. You know, it's unbelievable what this kid is. So I'm almost afraid. I'm sorry we did put the appliance in him, to tell you the truth. Anyway, but these are some of the side effects of stimulants. And these are 600 hormones. And if you look and see some of the ones that I've put in dark type, sleep disorders, night sweats, ADD, ADHD, fatigue not relieved by rest, allergies, incontinence and bedwetting. These are the things that are affected by hormones. They affect everything in our body. And when you have an interference in that system, believe me, it plays havoc. So we developed an appliance that will tend to correct the habits that influence sleep issues. And so we have a shelf where the tongue has to go up in the palate. We have little tabs back here where they can expand the arch, and it reminds the tongue not to come forward. We have little prongs in front. Well, it does. They have a handle. They can pull it forward and exercise their lips. So this appliance has been specifically developed to create habit correction. So we have a questionnaire, and in this questionnaire, I'm not going to read through these things, and you can't see them. I'm sorry, but there are questions like: does your child wake up at night? Is it restless sleep? Does he snore? How much does he snore? Does he snore 5 to 7 nights a week or 1 night a week? Does he feel sleepy during the day? And there are gradations from 0 to 5. And so we can determine how severe that child's problem is. So this is what we do. Anyway, from this, we determined that mouth breathing at nights from this particular study, 43%. Falls asleep watching television, 13%. Bedwetting is 20%. Restless sleep, 27%. Talks in the sleep, 31%. Snore at all, 37%. So you see that they have all these symptoms that we can determine how much. We can even determine how much improvement they will get from an average of about 200 children. So these are the percentages. For example, headaches, we can get 85% of them to correct 100% all the time. It's amazing what it does for that. We can correct bedwetting almost 40%, close to 50% here. Out of 2,000 patients that we studied, 75% of them had improvement, and the average improvement was 78%. So you can see that it is a dramatic improvement for these young children. So here's an area where they wore the appliance and they opened up the airway. You can see the airway has been opened up almost 6 times, 7 times what it would have been otherwise. Here's another case where the mandible has been moved forward and the airway that was before was very narrow, and it's opened up, even opened up the nasopharynx. So we're going to try and develop early treatment. So I'm going to kind of race through here. Most of the malocclusions are due to problems in crowding. And the crowding occurs from 6 to 8 years of age. So if we could prevent this from occurring, we could have a child end up over here rather than up here. So that's what we're trying to do. This is in agreement with many other researchers. The crowding of the front teeth is what occurs. After that, very little occurs afterwards. Here are 3 different children that have 3 different degrees of spacing between the baby teeth, contacts and crowding, and you can see the patterns are the same, but the fact that the teeth are bigger, permanent teeth are bigger than the baby teeth, and there are no spaces between the dentition is what creates the issues. We compared a crowded case with Morhe's sample of perfectly normal teeth, and you can see that spaces are lacking, teeth don't come in right, they come in lingually, they come in rotated with broken contacts, and this is what causes these tremendous degree of crowding and problems in the dentition. So we can measure the amount of spacing between teeth. A child has to have 6 millimeters of space between the teeth in order to have 100% of changes. Same with broken contacts. Here's a child with a missing lower incisor and has no expansion of the lower arch. And so we're going to try to straighten teeth before the collagenous fibers are formed. This is an electron microscopic view of collagenous fibers around bone, but around teeth they're organized in the same direction. So when a tooth erupts, it squeezes its way in, provided it's straight. So we're going to put an appliance in that has a template of straight teeth. And as that tooth comes in, if it's rotated, it will straighten itself in because there are no fibers, and it will become straight, and it'll push the teeth on either side to open up the space. So as the centrals come in, they open it up 1.5 millimeters. As the other central comes in, it opens it up 1.5 millimeters. We start the case when the first incisor breaks tissue. Okay? So we get this expansion, and we get 0.5 millimeter for each lateral, and at the end, in the upper arch, we get 2 millimeters for each central, 0.5 millimeter for the laterals, and 1 millimeter for the canines, on the upper arch only, not on the lower arch. So we can get about 5 millimeters of expansion just by controlling the eruption sequence of the teeth and make sure that they open up the arch. We never extract a tooth next to an erupting tooth. Don't ever do that, because then you eliminate all of this change. So this is a study that was done in Finland, almost 300 children. We had them put in an appliance, and the maxillary crowding, no significant difference. The control group went up like this, and the treated group went down like this. Same thing for mandibular crowding. So we can correct mandibular crowding very easily. And the expansion of the arches, we can get tremendous expansion of the arches. This is what a child normally will get in the posterior arch. This is from tooth guidance. And if they can, if they can push their, well, I guess we're going to go here. We're going to talk about crowding then. And the lower incisors start to come in, and if the centrals are lingually inclined or they're crowded, the tongue will usually push those teeth forward. The centrals will make room, but by the time the laterals come in, they're shortaged out. I mean, they have a struggle coming in. So most malocclusions are crowded laterals, not centrals. And so we allow these teeth to come in. You can see here there is even some space between the teeth. Here's the one left lateral coming in, rotated, broken contact. That tooth is never going to be pushed forward by the tongue. So an appliance is in there that's going to guide that tooth forward. Now the other one comes in lingually. And now they're all guided in, and the teeth are perfectly straight. This is almost routine for us. So if we start a case that has no more than 1 or 2 millimeters of baby crowding, it will straighten the teeth out very well. As far as spacing will be corrected because the permanent teeth are larger on the average by 7 millimeters on the upper, 5 on the lower. It will close those spaces. If you have an overjet, for example, in the upper arch, that will close those spaces as well. And the upper is closed by having a slightly smaller appliance if you need it. Usually that's not necessary. About 2% of cases will require that. Rotations. Teeth can be rotated. You see the laterals up here are severely rotated, and it's brought it in. Here's a lateral that's almost 90 degrees rotated, and it will bring it in because it has no collagenous fibers around it. Once it's straightened, then the fibers form around that tooth, and then that tooth won't get crooked again. So it prevents relapse. If you wanted to try to rotate that tooth, if you rotated it back, it would snap back straight because the fibers will pull it back. We're working the opposite way than orthodontists do. Orthodontists, the fibers are their biggest enemy because it causes relapse in 70 to 90% of cases. And so this way is a way of preventing that from occurring. Overbite correction. Overbite will increase 2 millimeters between 6 and 12 years of age. So we anticipate that. So we're going to correct the child and prevent the overbite from ever developing. So it's a prevention appliance. We're preventing crowding from occurring. We're preventing spacing from being a problem. And again, overbite and overjet in that same Finnish study showed that the control sample, overbite and overjet increased, and the overbite and overjet decreased. We allow 2 millimeters in the appliance, by the way, at this age because of future growth. So that's almost 100% corrected according to the way the appliance is made. Here's overbite. Overbite increases 2 millimeters. Almost all the studies in the English language show that to be true. And then it decreases slightly. Overjet increases a little bit, and this is what allows probably the overbite to increase. And so the overbite is the hardest thing for us to correct in orthodontics. And so what we're interested in doing is preventing overbite from developing. So here's an overbite that's over 1 1/4 millimeters, and it's going to become, if it's 1 1/4 millimeters, it will become over 3 millimeters, which is correctable orthodontically. So this child, we prevented the teeth from erupting at this level, upper and lower teeth. So they end up with a perfect overbite. We want this to be prevented. An overbite is so hard. This would take me probably 2.5 years to correct, because this overbite is going to cover the entire gingival tissue of those teeth. Bruxism. Child is extremely bruxated, so we just leave the younger appliance in for a longer period of time, let the first permanent molar super erupt, and it drives the bite open, and we can control the face height by doing that. And the end result, oops, excuse me, yeah, I'm pushing the wrong button here. Anyway, this is a girl with an overjet of 8 millimeters, and she came in. I did not know about sleep at this point, but she would not look at me. She wouldn't talk to me. She would hide her face in her mother's lap. She came in 1 month later, and she was all personality. She talked, she was smiling. I couldn't believe what was happening. I thought it was because she knew that her teeth were going to get straightened. It wasn't that at all. It was the fact that we had corrected her sleep issues, and we prevented her mandible from slipping back because she already had a retrusive mandible. So we've advanced the mandible, we've straightened out her profile, and she has a perfect dentition at 8.5 years of age. This is mandibular growth. This is interesting because we increased the mandibular growth in those finished children by 54% over the control sample. And the reason for this probably is that we increase the oxygen level. We've been trying to get after them to reopen those cases. We've offered to go over there and do the research ourselves, but they won't let us do that. And I would like to be able to see what the airway was at the beginning and at the end. And I'd be willing to bet that the airway has been opened and increased the growth because of the increase in oxygen. Open bite also can be corrected with this appliance. There are pads in the back that can correct it. Pseudo class 3s, where they bite down and they're touching, and so they shift forward. Well, these can be easily corrected also. Here's a child that corrected it over a weekend. He wore the appliance full-time and corrected the characteristic here. This is a minor class 3. This is not as major as this is, but he was end-to-end. And this is the progress of class 3. This is the progress of a normal child. So we would like to put an appliance in a class 3 child and limit the amount of changes that are going to occur. And it might do it in more minor skeletal problems, but it is not meant to be a skeletal corrector. Here is a true skeletal class 3, and we were able to correct it, and it has remained corrected. This is at 11.5 years of age, and you can see that it's held quite nicely. So minor ones you can do something about. Class 3s are not a problem unless the upper arch is back and closes up the nasopharynx. So class 3s don't affect the effect of sleep too much. Gummy smiles also. We can correct gummy smiles, but this has really very little effect other than for the health of the tissues and the appearance of the case. And here's a lingual inclination, can change that and bring the mandible forward and improves sleep issues. And this is the TMJ. You can't see this, but we have absolutely no change. We have improved the TMJ compared to children that come into orthodontic treatment almost 540%. So I'm just going to switch all of a sudden to the mixed dentition. We're going to quickly go through this. Crowding. Now we have to put actual pressure on the teeth to move them because the collagenous fibers have formed around the teeth. So crowding we can correct. They do have to wear the appliance a couple hours a day and at night. The other appliance they only wear at night. In fact, they can wear it 1 hour while they sleep and it will straighten the teeth even though they haven't worn it all night long. But this does require some active wear, but it is good for correcting upper crowding as well as lower crowding. It'll correct overbite. In fact, this was my first patient that I experimented with, and I gave him an appliance to see if we could correct the overbite while the teeth were erupting. When he walked in and had an overbite, I think this was the day, 6 months later, but I saw him 3 months later, and we took a cephalometric film on him, and he had corrected that overbite. I said, how much did you wear that appliance? He said, I only wore it 1 hour a day and at night. And I tell you, my eyes almost fell out of my skull because I have never corrected an overbite so fast. This would have taken me at least 2 years to correct at 1/10 of a millimeter per month. So it was amazing. Sometimes patients will teach you things. I had a boy that walked in one time, and he was a retention patient early on in my career. And he had a lower crowding about 3 millimeters. I said, I'm going to have to put braces back on that, and it's going to take me 6 months. He said, Doc, don't worry about it. He said, I can straighten those in 2 days for you. I said, that's impossible. He came back 2 days later, and his teeth were perfectly straight. And here I'm an orthodontist. I'm actually asking a 12-year-old child how he did that. He took out of his pocket a black rubber thing in 3 broken pieces, and he assembled. If I hadn't seen that, I would have never believed it. And that's what stimulated me to develop that first appliance, because I saw what something can do other than braces. And believe me, we can get a result that's equal or better than with braces in a shorter time. 4 months instead of 2 years, 5 months, 6 months sometimes. Anyway, here's the overbite of the first boy, Tom. He didn't wear the appliance very much. And the only reason he could do this with such little wear was that he was going through a growth spurt at the same time, but he also had eruption of teeth, which we controlled. So anyway, facial profiles we can change. We can change overjet. This boy, I'm sure, had a sleep problem because it was years before I did sleep things, and I was interested in it. And he had a double lower incisor down here, and we corrected it, and here he is at 25.5 years of age. The case has stayed quite nicely. Here's facial profile. Here's a crossbite, overbite, teeth in different directions, and the canine is in crossbite. We've corrected it out, and this all occurred within 4.5 months. So you can see that the potential is here that we can correct. This boy had lingually inclined upper incisors. They've been straightened out and let the mandible come forward. But the main thing is that we prevented the mandible from going back at night, so we keep it forward. Spacing, correct spacing. TMJ problems, we can correct TMJ problems. And so we can avoid extractions in many cases. So these are all the things that we can do, and we've gone through most of these already for you. And I think my time is about up, isn't it? I'm ready. Anyway, phthalate-free, doesn't have any plasticizers in it. The materials that we use, the only material that's added in there is FDA mineral oil. And so the plastic is in agreement with FDA standards. And I might tell you that Beth Rossellini is going to give a lecture at 1:30. I would like all of you to attend it and listen to what it is that she can do in a practical sense in her practice.